Hello everyone, how are you? Welcome to another series of lecture on recalls. So let's see here. Today we are going to discuss the September 2023 recalls. So first question, let's see the question. Posterior medial approach Baker cyst, most superficial susceptible to damage. So here they want to know that a Baker cyst which is present in the knee joint and it is located in the posterior medial side. So the most superficial structure that may damage. Here the options are sciatic nerve, tibial nerve, sural nerve, common peroneal nerve, and saphenous nerve. So we have to find out one of the option which may be damaged during the posterior approach of removal of the Baker cyst. So first of all, let's see the Baker cyst. So here we can see this is a Baker cyst which is located in the posterior aspect of the knee joint, and here we can see this Baker cyst is arising from the knee joint and it goes upward and finally it goes just under the skin. So when we give incision this level, so the most superficial structure will be damaged first. So here we can see when we give any incision here or here or here, the structure which is located this area, there is chance of damage at first, then other structure, and knee joint, it is very far from this Baker cyst. So here we can see, so let's see the superficial structure. Here we can see just posterior medial aspect. Here the great saphenous vein and saphenous nerve, when they ascends in the medial aspect of the leg at the knee joint, it goes backward and finally it go again back to the front part. And here in the second picture also, here we can see the nerve, it when in the knee joint it goes in the posterior part, and this structure are the more superficial. Here we can see another picture and this picture, this whitish structure, this is very important. The whitish structure, we can see this is the whitish structure in the whole length, and some of the structure which lies this whitish structure. And what is the name of the whitish structure? It is the deep fascia of the leg. So the deep fascia of the leg, any structure which is located above the deep fascia, it is the most superficial. So here we can see this is the knee joint, this point, this is the knee joint, and here we can see this is the medial part, and here this is the lateral part. And in the medial part, here we can see a vein and a nerve is going, and which is the great saphenous vein and saphenous nerve. So this point is very important. So when we are giving incision in the posterior aspect of the knee joint, there will be chance of damage great saphenous vein and saphenous nerve. And here we can see this is the content of the popliteal fascia. Popliteal fascia also may get damaged, but they are the most deep structure. And here three important question arises. That means the, let's see, these are very important. That one of them is the tibial nerve. So a frequently asked question, that the common peroneal nerve is divided into the tibial nerve and the sciatic nerve divided into common peroneal nerve and the tibial nerve at whose level? It is the upper part of the popliteal fossa. Another important question, that means the most lateral structure is the common peroneal nerve in the popliteal fossa, and most superficial tibial nerve. The tibial nerve lies most superficial in the popliteal fossa, not under the skin. It is in the popliteal fossa, within the boundary of the popliteal fossa. These structure are deep structure, but among them most superficial is tibial nerve, then most lateral is common peroneal nerve, and most deep is popliteal artery. So these 3 points is very important regarding the popliteal fossa content. So here our answer is ready. It is the saphenous nerve. Two important structure. One is the saphenous nerve, another is one is the greater saphenous vein. They lies just under the skin above the deep fascia or superficial to the deep fascia. So there is chance of damage of the saphenous nerve during the posterior medial approach of the Baker cyst excision or Baker cyst. The other structures such as the sciatic nerve, tibial nerve, and common peroneal nerve, they are the content of the popliteal fossa, and they are not superficial. They are the deep in the popliteal fossa. And the sural nerve, it is located into the lower limb, but it usually not reach up to this posteromedial aspect of the knee joint. Here we can see this is the sural nerve. Here we can see this is the sural nerve. So this sural nerve, it reaches up to here, but it not goes in the medial aspect. The second question of the recalls MRCS September 2023. Hodgkin lymphoma histology, that means the histological feature of the Hodgkin lymphoma. It is on incomplete question, so let's see directly the histology. Here you can see this is the prominent nuclei. So prominent nuclei, it is feature of the Hodgkin's lymphoma. So here we can see this is a histological slide of the Hodgkin's lymphoma, and here we can see this is the normal cell, and it is the phalanges of the cell after Hodgkin lymphoma. And here we can see this nucleus is enlarged, and it is known as the Red-Steinberg cell. So the Red-Steinberg cell, it is the histological feature of the Hodgkin lymphoma. And here we can see the nucleus, which is very large, cell also very large. So here we can see another view, and here we can see the prominent nuclei. The another picture, these two nuclei, it is different from other, and it is known as the Red-Steinberg cell, which is clinical feature, which is the histological feature of the Hodgkin lymphoma. So the histological feature of the Hodgkin lymphoma is the prominent nuclei or Red-Steinberg cell nuclei. The third question, chest X-ray foreign body usually settle down. That means any foreign body which inhaled by a man or children, and which settle down in which part. Typically different parts, different substances may be eaten by children or any other. Then usually when settle down, here the options are the right lower lobe, middle lobe, right upper lobe, right lower lobe, and left upper lobe. So we have to find out one of the option at which the foreign body is usually settled down. So let's see details. The right main bronchus is shorter, wider, and nearly vertical compared with the left main bronchus. So it is the most important cause that the right main bronchus is vertical. So this point is very important, as it is more vertical. So the foreign body usually settle down in the right lungs. And here we can see, as a consequence, inhaled foreign bodies are more likely to enter in the right main bronchus than the left. So it is the direct snapshot from the Bailey Lab surgery book. And here we can see the picture of a bronchial tree, and here we can see this is the trachea, and this is right bronchi, and this is the left bronchi. And here we can see this is relatively vertical. Here this picture is also very clear. This is the right bronchi, and relative to the left main bronchi, we can see this is the larger, wider, and more vertebral. So when foreign body enters, it enters into the right side. So this is the difference in short about the right main bronchus and left main bronchus. Here we can see the right bronchus, it is wider, more vertical, and shorter, and it is supported by C-shaped cartilage, and its angle is 20 to 30 degree, which is less related to the left main bronchus, which is 40 to 60 degree. So these three important point, it is right main bronchus, it is wider, vertical, shorter, and left side it is narrower, more angular, and longer. And the degree which is in the right bronchi, it is 20 to 30 degree, which is less. So there is a chance of entry of this foreign body in the right main bronchus. So it is now ready that any foreign body which enters in our trachea, it goes finally into the right lower lobe. And the lower lobe, because it is due to gravitational factor. Now another question which gives an ileoanal pause. In patient ileoanal pause, that means the whole of the large intestine is removed in this patient for any cause, and the patient is on metronidazole. Now common side effect of it, that means we have to find out the common side effect of the metronidazole in this patient. That means in ileoanal pause patient taking metronidazole, so what is the most important common side effect. Here are the options are ileoanal fibrosis, peripheral neuropathy, coagulopathy, ileovesical fistula, and pausitis. So first of all, here we can see the ileoanal fibrosis, ileovesical fistula, and pausitis. They are the direct complication of this operation. That means the ileoanal pause. So they are not the complication of the metronidazole. So this point is very important. That the ileoanal fibrosis, ileovesical fistula, and pausitis, they are the complication, but they are not for the metronidazole. This complication is not for the metronidazole. This complication directly from the ileoanal pause. Another two options, peripheral neuropathy and coagulopathy. Answer is located within these two options. So here we can see the therapy for treatment of prevention of pausitis of metronidazole. Here the side effect, first of all, vomiting, metallic taste, and temporary damage to the nerve. So among them, I think the most important side effect is metallic taste. The person who takes metronidazole, only he or she can experience the metallic taste of the metronidazole. So here we can see the common side effects of metronidazole. The epigastric distress seizures, which is less common, metallic taste, which is very common, darkening of the urine, peripheral neuropathy, pancreatitis, hepatitis, fever, and reversible neutropenia. Here this is the neutropenia, not coagulopathy. This is neutropenia. So here we can see the peripheral neuropathy. It is one of the side effect of the metronidazole, but I think the most important side effect is the metallic taste. So our option is later. And here we can see the complications, and this complication is the ileoanal pause operation. And here we can see pause related pausitis, pause vaginal fistula, perianal abscess or fistula, anastomosis stricture, and pause unrelated such as ileus and incisional hernia. So they are the incision from the operation, not for metronidazole. So our option is now ready. It is the peripheral neuropathy. It is not coagulopathy, because it decreases neutrophil, and neutrophil is not related to the coagulation factor. And other options such as ileoanal fibrosis, ileovesical fistula, and pausitis, they are the complication of the ileoanal pause, not for this metronidazole. Another option, which is the reciprocal of absolute risk reduction. That means we have to find out the reciprocal of the absolute risk reduction. It is relatively hard, but it will be very easy. And first of all, see the answer, as the recalls is not complete scenario. So this option is number needed to treat. So reciprocal to absolute risk reduction, it is number needed to treat. So now see details about the absolute risk reduction. The absolute risk reduction is the decrease in risk of given activity or treatment in relation to a control activity or treatment. So in case of absolute risk reduction, we give treatment a group, both disease, the both group are disease group, but one group we giving the treatment and another group we just watch and wait. So it is the inverse of the number needed to treat. So the absolute risk reduction, it is inverse to number needed to treat. That means we are getting out of treatment of this patient and cure without treatment. And here the absolute risk reduction is usually calculated to different treatments. That means, for example, consider surgical resection X versus watchful waiting Y for the prostate cancers. That means all the patients have prostate cancer. We divided in two groups. In one group, we giving treatment. That means we are going surgery or treatment. But another group, we are just waiting to see the different result. A definitive endpoint such as 5-year survival is required if the probabilities of P of X and P of Y of the endpoint are known. Then the absolute risk reduction is calculated, and it is P of X minus P of Y. So the inverse of absolute risk reduction is the number needed to treat. So absolute risk reduction, it is inverse that we given the treatment. This is useful in determining the cost versus benefit of many treatments. That means if the result is same, then we are going to not giving treatment because it is cost effective, it is costly. such as we are going through operation, then we going to chemotherapy, radiotherapy, or other therapy. This is very very costly, and if we give no treatment, then no cost. So our answer, that is the absolute risk reduction. The answer is the number needed to treat. That means the reciprocal. That means opposite the absolute risk reduction. It is number to treat it. Thank you all.